It's Dr. Waddell Brooks Sr., your host, and this is Community Forum. This evening we have three exemplary people from the Captain James A. Lovell Federal Health Care Center in North Chicago, Illinois. And we're going to be talking about the PTSD, the post-traumatic
stress
disorder, and other topics there. So if you have some friends that you'd like to have tune in, be sure to have them tune in channel 17 and listen to it. It will be greatly rewarded for them. To my immediate left is the producer of this program, John Patrick Baer. He's a PhD, clinical psychologist at the James A. Lovell Federal Health Care Center. And we will be mentioning that quite a few times. As you know, that Senator Kirk was very instrumental in the organizing of the Captain James A. Federal Health Care Center. James A. Lovell was an astronaut, as you know. And Senator Kirk, Congressman Kirk at the time, was instrumental in combining the Great Lakes Hospital and also the Downey, the Veterans Hospital. It's probably the only unique situation here in the hospital in the country. Right,
yes.
John?
It is indeed.
John developed an outpatient program for combat veterans and their families. He's an associate clinical professor at the Rosalind Franklin University of Science and Medicine. And Rosalind Franklin is just south of the James A. Lovell Federal Health Care Center. John has taught and supervised clinical psychology students and interns as well as psychiatry residents for 19 years. Dr. Baer has published and researched on PTSD as post-traumatic stress disorder, anxiety disorders, team and leadership effectiveness, motivational counseling, and expressive therapies. He completed his doctoral work at Northwestern University and is past president of the Chicago Center for the Study of Groups and Organizations. To John's left is Bharathi Swaminathan. Thank you. She's a MD, serves as a staff physiatrist, physical medicine and rehabilitation at the James A. Lovell Federal Health Care Center. She cares for veterans, AD members, and dependents with both acute and chronic musculoskeletal problems, returning OIF, OEF. And I'd like to have John tell us what those initials.
Well, OIF is Operation Iraqi Freedom,
okay.
And OEF is Operation Enduring Freedom.
Okay, I remember those, but I couldn't recollect right away. I know you have it right at the tip of your tongue. This is very, very important. With traumatic brain injuries and performing electrodiagnostic testing in patients with neuromuscular and peripheral nerve diseases. She also holds a faculty appointment as an assistant professor in the Department of Physical Medicine and Rehabilitation at the Rosalind Franklin University of Medicine. Dr. Swaminathan? Need some help there. Currently involved in the 2 IRB-approved prospective studies in collaboration with our psychology department and pulmonary department at the institution. Both studies involve returning combat vets from recent conflicts. One of the prospective studies recently was accepted for presentation at American Thoracic Society 2014 meeting. She completed her medical school in Maduro, Kamaraj, University in India. She completed her residency training in PM&R and clinical neuropsychology fellowship and currently board certified in both. And our anchor person is Dr. Danielle Saccone. She's a clinical psychologist with special interests in neuropsychological and neurodevelopmental difficulties. During a 5-year educational hiatus, Dr. Saccone has been employed and received specialized training at multiple locations, including residential treatment, private practice, inpatient hospitalization settings, both rehabilitation and psychiatry. And at the Captain James A. Lovell Federal Healthcare Center, Dr. Saccone completed her predoctoral internship at the William Beaumont Army Medical Center in El Paso, Texas, where she worked with active duty personnel and their dependents. She is currently completing fellowship with the North Shore Behavioral Health as a neuropsychology specialist and holds a part-time position through CARES at the James A. Lovell Federal Healthcare Center, where she continues to study post-traumatic stress disorder in relation to traumatic brain injury and other neuropsychiatric
Sequela.
John, I've given quite a bit of background on the three of you, but tell us, why is it so necessary to inform our listening audience about PTSD and brain injury?
Dr. Brooks, on behalf of all of us, we want to thank you.
Okay.
We want to thank your viewing audience because this topic is very important to us and it's very important to society, and we're going to tell you why.
Okay.
Let me begin by just saying PTSD, post-traumatic stress disorder, and traumatic brain injury have been around forever. However, it's only in recent years that we've studied these and we can actually begin to treat them with some degree of effectiveness. And many of your viewing audience may have people in the family who have served in the military or been in some kind of accident or disaster where they have PTSD and traumatic brain injury. We want to invite you to consider Lovell and consider what we have to say tonight as a way of helping you gain information. In history, after war or disaster, people would have traumatic events and they would have the same symptoms that they have today, but they were treated by sweat lodges and Native Americans, or the warrior circle and Native Americans. But in South America, in Africa and in Asia, there were always rituals and ceremonies after war or after disaster. We think that today we're going to talk about why it is we can move beyond rituals and ceremonies to more scientific treatment and scientific research to understand these phenomena.
Okay, John, then we have to think beyond military. I think people have come to understand that PTSD is caused by injuries in military, but it could be in civilian life too, right?
Absolutely. Dr. Swaminathan?
Just to add to that about traumatic brain injury,
Okay.
basically any type of external trauma to the brain is the traumatic brain injury. The most, simple definition is concussion. I'm sure we all watch sports and football.
Okay.
You see the players get hit, they get knocked down, and they may lay on the ground for a minute or so, then they get up and walk away. So our traumatic brain injury clinic at Lovell mainly focus on identifying the returning combat service members with mild traumatic brain injury. Let's say they are at war and they had a severe injury. Usually they get the help right away. They are airlifted to Germany and to Walter Reed, and they are treated. So those veterans who may lost consciousness for less than half an hour or dazed and confused but were able to function, those were missed. So our main focus at Lovell TBI Clinic is to identify the returning service members who suffered the concussion, who is still suffering from headaches, dizziness, which is affecting their function, to treat them accordingly.
Well, I guess, John, how is the James A. Lovell Federal Healthcare Center involved with these problems?
Well, we're very deeply involved, and we're proud of our programs. I would like to have Dr. Ciccone say just a little bit more about post-traumatic stress disorder so your audience has some details.
Okay.
Sure, and especially to address that question about not only being an issue within the veteran population or active duty population, but within the community.
Okay.
So definitely can find it anywhere. And the first and foremost situation that has to, I guess, come to light for diagnosis, right, to say that you have something called PTSD, because a lot of people don't know even what that is, you have to be exposed to a stressor of some sort, a stressor that is traumatizing, is really bothersome. That could be either directly or indirectly. Directly meaning you were actually there in that situation and it happened to you. Whereas indirectly you can have, let's say, a family member who has been in service, who has been to combat, and comes back from war with their own trauma and their own symptomology, but because they continue to maybe talk about it in the home on a pretty regular basis with their wife may start to develop those same symptoms, and that too is representative of PTSD. Some of the symptoms, of course, that are fairly, I guess, consistent with PTSD, they usually fall under a few areas. We call them clusters, and those are avoidance, hypervigilance or hyperarousal, change in arousal systems, which is related to negative cognitions, and as well as some re-experiencing symptoms. And I think something that is usually seen on TV, right, is some of that re-experiencing, something like flashbacks, where maybe a situation will trigger someone who has PTSD. Let's say, for example, that they hear a loud boom outside, and they're no longer in war, they're here and readjusting to civilian life. That loud boom could send off some different pathways within the brain that are related to trauma that had occurred previously. And so they may hit the floor. They may then start to experience exactly what they experienced at that time. They can smell some of those same smells, whether that be gunpowder or even blood, fire, etc. And they sometimes taste things, whether that be metallic or anything that really is reminding them specifically of that situation. So kind of like them really being there again. And that's one of the more bothersome symptoms, of course. Some of the other ones that I was mentioning, like an increased arousal system, so really kind of being alert everywhere they go, feeling really uncomfortable with even the thought of having to go to Walmart to go shopping, or any said store, right? But that's one of the big ones because that's where there are a lot of people. So they become more isolative, more withdrawn, sometimes become a little bit more negative, really difficult to see the positives in life, and hence they try to wrap themselves up and don't really want to be bothersome to anyone.
When you spoke to our North Chicago Rotary Club, there's a great interest in there. There are a lot of arousal of questions that were asked and so forth. So I want to thank John again for inviting you to come, and also being the producer of this program too, to talk about it. But some of the questions that you got there, the interest that questions that they asked.
The questions that they asked?
Yeah, the type of questions that they asked about PTSD.
We're somewhat of these really trying to figure out what it is, period, because that is where it may be a stigma, right? Do you have it or do you don't? And if you do, we don't know what to do with you. And usually that stigma is also very much negative. So I hear most often, that someone's really aggressive, or so they must have that. They may have hit someone, and that's not quite accurate. There are definitely a skew of symptoms that people present with, and each person is very unique and individual. And I think that's really what we were trying to get across at Rotary, was that a lot more people who would maybe not be so willing to get the help, hopefully would get some help by us providing that education.
Okay, the help come from the community also as well as from the veteran?
Of course.
Can they come to get treatment at the James A. Lovell Federal Health Care Center?
A veteran is what you were asking?
It has to be a veteran though, right?
It has,
It has to
be.
be,
Yeah,
okay.
right, right. So what we do service there, a veteran, we have veterans active duty as well as their dependents. And,
Okay.
And the
and those are the
retirees.
persons who can receive, yes, and the dependents are a huge plus these days too, big transition. But there are, of course, a lot of other places that can assist should that be an issue within the community. And I think we're all very well aware of those, so we'd be happy to take at least information from, viewers who maybe weren't involved within that and maybe provide them with a proper referral.
Now, how do veterans find out about I know this is one way. We're reaching
Right.
over 100,000 people here in Comcast, and the program airs in Kenosha, Wisconsin, and it also can TV in Chicago.
Right.
So it's widely seen. But otherwise, how do people, the veterans, find out about the PTSD program?
Great question, and I think Dr. Swaminathan would be the perfect candidate to further
But
discuss,
the-
as we did recently talk about our
The brain
outreach.
injury.
Yeah.
Right,
Yeah.
our outreach.
So as opposed to previous wars, our military and the Department of Veterans Affairs are doing a wonderful job reaching out to the veteran.
Okay.
So we do have what we call a post-deployment case management team. So when they are aware of the service members come back to the community, they do send out welcome home packet.
Okay.
They actually, we don't wait for them to call us, they call them to, either through phone or mail, or we do have a Facebook page. They could go online and register. So they reach out to them and educate them to use all the services available to the returning service members.
I know you brought a brain, with you here, but what happens to the neurological portion of the brain?
So basically, whenever the brain injury is any kind of trauma to the brain, so you do have the skull
Okay.
and the brain is inside. So remember, you are hitting a head rear-ended when you are driving a car.
Okay.
So your head goes back and forth, and the brain moves forward and backwards
Okay.
inside the skull. It
Yeah.
cannot move anything beyond that. So in case of this mild traumatic brain injury, the mechanism is the axons or the neuronal fibers, they get stretched. So most of the time the veteran have injury or contusion to their frontal lobe and near their ears called temporal lobe. So afterwards they do have difficulty with executive functions such as reasoning skills, planning, or personality changes. And when the temporal lobe is affected, they get difficulty with their memories. They may remember their date of birth, their social security number, but they may not remember where they put their car keys. So
Okay.
they may end up, they have difficulty forming new memories. So those are the things that affects their daily
Is
activities.
that when dementia is formed?
Dementia, as the name says, it's more of an older population, but these are
Oh.
younger combat vets we are talking
The
about.
symptoms can overlap.
Overlap,
Absolutely.
yes.
But the traumatic brain injury is when the brain has this many tears. The brain actually has tearing. In contrast with PTSD, the area of the brain here, the amygdala and the hippocampus, become somewhat dysfunction because of overstimulation, where the emotions are processed. So different than a traumatic brain injury where there are tears, as Doctor
Right.
mentioned, around the brain. With PTSD, where you're overstimulated by tragedy, by exhaustion, by fear,
Yeah.
it's more in the emotional processing area of the brain where we see that there's some dysfunction. And in these current wars, Dr. Swaminathan, How frequently do we have both PTSD and traumatic brain injury?
So as you know, in the Vietnam War, we all talked about Agent Orange is the main
Yes.
injury. So in current conflict, traumatic brain injury is called signature injury of the returning, service members. So again, going back to the Department of Defense data, is over 4 million troops were deployed to Iraq and Afghanistan from 2000 up till 2014. So of those, close to over 300,000 sustained some kind of traumatic brain injury. And most common is the milder form, 82%. So since their injury is milder, they have more awareness of the trauma, so their post-traumatic stress is higher in the current conflict than the previous one, so close to 40%. So when we are treating the patient, we cannot treat them individually. It takes the whole multidisciplinary treatment team to treat the single service member. Right, Dr. Bayer?
Absolutely.
I want to get into that treatment because you say that there's not a cure, right, Dr. Baer?
Exactly.
Now, in treatment, is the treatment, you have short-term and you have long-term treatments?
Absolutely. We're very proud at Lovell Federal Health to be really one of the premier sites for post-traumatic stress disorder and traumatic brain injury. We have a residential program where veterans come from around the country, many from Michigan and a lot from Wisconsin and a lot from Illinois. But we have over 200 that come for the 6-week program, every
6 weeks.
6-week program. Many of those will return to their other providers, and many will come back and do the program again. Sadly, what happens is that PTSD and traumatic brain injury, the first part is just getting people to come in because so many people do not seek help, and they suffer with substance abuse, with violence in the home, with depression, with suicide. So there's all these problems that happen when people don't get help for PTSD or traumatic brain injury. So we're proud at Lovell to have the residential program, and we have really one of the larger outpatient programs. So that, for example, every day of the week, I have between 2 and 3 groups or classes of veterans, and we also have classes and groups for partners of veterans. We have their families come in. We also have large community meetings and expressive arts. So we have really a full-scale offering. Plus we have substance abuse programs for those people who need to be treated for substance abuse along with their PTSD and traumatic brain injury. And excellent physicians and health treatment as well.
Well, I like to ask Dr. Ciccone, what piqued your interest to get into the field?
To get into the field,
I know
generally
they
speaking.
really need you, Dr. Baer, just admit you're an outstanding physician, But what piqued your interest in it?
To get into the field in general, well, actually, I can very briefly say that what it was at the many moons ago, right when I first started this trajectory of my career, I really was interested in developmental PTSD, so different post-traumatic stress disorder. It's a much different picture with children and adolescents, and so after working with them for approximately 6 years, I decided that I would kind of keep it in the family, and that my grandfather had served in the military, my father had served in the military. Both had their own unique difficulties as well. They both handled them very differently, and it's something that I was extremely extremely excited to start work, not only for the veterans and for the active duty personnel, but for their families who are probably questioning just like I do as I was becoming an older adult, not so young in the field. But nonetheless, I think that's primarily why I had actually come into the field, and it has now struck a passion, which I know it has in the rest of the persons that I work with. My colleagues are excellent and have this incredible gift of empathy and of care, and truly wanting to assist our veterans and active duty personnel and their dependents. They have served for us, and we definitely have the passion to want to serve them.
Dr. Samantha, I'd like to ask you the same question. What piqued your interest to get into the field?
So the physical medicine rehab is, we look at the whole person. We
Okay.
take a holistic approach. So we not only treat that one headache or dizziness, we look at their psychosocial, we involve their family early on in the care. So our goal is to restore their function and enhance their performance so they could get back to being, even if they have some impairment or disability, they will be a productive citizen. So,
No, I mentioned a friend of mine
Uh-huh.
just yesterday,
okay.
and of course he'll be buried by the time this airs. But his name is Joseph Wall, and he had a headache, he had a series of headaches that he didn't go to the doctor to get
Okay.
checked out. And he was texting and his sister and so forth, and he just keeled over.
Wow.
It's going because of a series of headaches. Now, I don't know. Now, he was an athlete from way back, when he was in high school and college and so forth,
Right.
but I don't know whether he had been suffering from brain. But when you have the headache, I guess you have to go to the doctor and get
Yes,
checked out, right?
absolutely. You have to go to emergency room or call
don't know what,
911. Yes. Because medicine have came a long way. Before it will take us 4 hours to do a neurologic exam to diagnose a stroke. Now it takes 20 ml of contrast and you can look at the brain.
Oh, my
so,
goodness, right.
so we strongly encourage anybody with headaches, especially if they have the severe headache they never heard in their life. That's a clue that you need to go. There's something emergency going on.
And listen to this. I look at my case. I'm a veteran, a Korean veteran,
Okay.
and it was peacetime. We were
Right.
replacements in
Okay.
Korea. But we went through the basic training and the boom, the noise,
Right.
and charge. And I feel myself, since I'm hearing about all this,
Right.
every once in a while I find myself counting cadence, and I was wondering whether this was a kind of temporary thing you mentioned about flashbacks and so
Right.
forth. But my wife is not home though, so she doesn't know I'd be counting cadence and doing a lot of things. And I think about it, did that have some effect? Of course, maybe marginally, but not a great thing there, But that type of thing could. You mentioned about flashbacks, but would it be considered?
Well, it's low level, and
Yeah.
truly, all of us have intense memories of those very important times in our life.
Right.
First love experiences, first successful sport experiences. But when you're serving your country and you're serving a foreign country in a dangerous time, of course it's going to be a profoundly important experience, and memories will come back. A little different, though, from PTSD, where they come back and they can really handicap you.
Yeah,
With
stay there.
PTSD, they can come back and they can make you stay in the basement and feel bad and walk around the house with weapons and feel like the enemy is coming at any time. And some of your viewing audience know what we're talking about, because there are people out there in Lake County who have that level of hypervigilance and re-experiencing, where people are unable to get out of the house or come out in crowds because they just expect that it's going to be a dangerous situation. So you're talking about a low-level kind of
Right.
acute memory.
Yeah, just to give an example, one of our recent service member, whenever he comes for an appointment, his wife has to drive him. Because he said whenever he drives and when he sees the garbage can on the streets, he feels that there will be some, IED or bomb inside.
Yeah.
So it took a while, I believe 2 years for him to get over that fear just to drive. So the wife has to take off work to bring him there. So it affects the whole, the family and the entire community. So
Well, what about separation of family? Does it cause, what's the percentage? Do you have any idea of the family the wife said, I just can't take it anymore, or vice versa? Because women get, women serve in the military too, so
Right.
they could get the PTSD also. Any idea?
It's a high rate. Of those people who have chronic and severe PTSD versus low level will have held multiple marriages, and many of them live alone and they have unsuccessful relationships or unhappy relationships. And again, in your viewing audience, there are families and marriages where there's anger and there's such conflict that we invite your viewing audience, if the family or marriage is at that level, to really please come for help. Because it is very common with severe PTSD that you have relationship problems.
Now, when you say come for help, how do they contact you?
Well, we have right here our number, and we're certainly going to post our website address on your website. But they can call 847-688-1900, and they can ask for Dr. John Bear.
What is a typical day at the John Bear facility there? Is there such thing as a typical day?
Difficult day.
The typical day is both of inspiration and suffering and hard work. And I just want to say that I'm so proud of the people that I work with. As Danielle and Dr. Ciccone was saying, we have in our PTSD programs Dr. Tony Peterson, who manages the programs, and we have so many excellent psychologists and social workers and mental health workers, so it's a huge team. My day, and I think all of their day, is one of spending an hour or 2 hours or having a group for 2 or 3 hours. And really, you work with veterans at different levels of their recovery. At the front end are people who are just learning to be able to come in, because people don't like the government. They don't want to come to a big brick facility, even though our Captain James A. Lovell is quite a handsome facility. It's big and it's ominous, and when you've served in a war and you feel bad, it's hard to come in. So that's why we have all the outreach. But when people come in and they're in the first stage, the first thing they need to do is get some trust, feel safe, meet some other vets, hear from other vets, and see other vets who have made gains. So often when we have new men or women come in, staff will introduce them to other vets, welcome them in a low-keyed way, try to make them feel at home, because it takes a while before you feel like you can trust the government again when you've been hurt by war or traumatic brain injury. So then, after a period of time, people find their voice, either through individual therapy or group therapy or couple meetings or family meetings, and they can talk more about what happened. And then at some point they can do some trauma work, which our residential program specializes, the 6-week program. But all of us do trauma work, where people really can unwind some of the traumas that are unspeakable. It's so hard to talk about, and vets would never talk about those things unless they were feeling very safe. It takes a while before people can do that level of therapy. And then later on, people move into very generative roles. As you know, Dr. Brooks, we've had veterans come to be on this television show. We've had vets come to Rotary Club. We have vets leading musicians, putting out CDs. We have vets who are taking leadership roles in the community, people who are writing books. So you move from the initial phases of being able to just come in and trust the government to more advanced phases, where you're being generative and you can really give back and your family is more comfortable with you. And I just, as you know, we look forward to other television shows when we can have some of our vets come back on, so that your viewing audience can hear from the men and women who've really made advances through our programs.
We had a couple, I guess they wrote songs, I guess, and was played right on the program here, that the audience could see it, you know.
That's about 6 years ago.
Okay.
Time to do it again.
It really flies, is that right? You know, I mentioned some initial OIF and /OEF, but tell us a little bit about those two programs, those two veteran programs.
Well, we have a specialized, as Dr. Swaminathan was saying, to welcome in the...
Right. So OIF means Operation Iraqi Freedom.
Okay.
So basically it is the war that started from 2001 and it ended in 2003. And then Operation Enduring Freedom is the one when they are deployed to Afghanistan. That's again from 2000 and it's ongoing. And the current war in Iraq, they call it Operation New Dawn, OND. Yeah.
OND now.
Yeah. So
Operation
it's New Dawn.
Okay.
So all these three comprises the global war on terror.
So the government is really highly interested
Right.
in assisting all the veterans.
All of the veterans, yeah. Just to add to that, we also have a caregiver program to help with the family members, and also the post 9/11 GI Bill,
Okay.
which helps them to go back to school. So they pay for the tuition plus room and board. Compared to the pre 9/11 bill, they only paid the tuition.
Okay.
But this one, they paid the tuition plus room and board, so they don't need to actually work and, go to school. So the only thing we ask is, I believe they need to maintain a C average or not fail a class.
Okay. Okay.
Again, through our TBI clinic, we have the multidisciplinary team. So we have a physiatrist, a neuropsychologist who helps them with the memory. So if they have difficulty with school, we do write them letters to the school to give them more time or more, the help they need. And also a memory specialist who helps them with all different memory strategies. So one more thing is the telehealth also, because some of the veterans live far away from us.
Oh, yes.
So we do offer telehealth. So if they have an appointment, they do get a link in their own computer, and whoever they have the appointment with, they could see each other and then work on it. So it saves time, money, and travel, and more convenience.
Yeah, Dr. Bear mentioned about veterans come from Michigan here.
We do have veterans
Right.
from Michigan and from Indiana, from Wisconsin, many from Wisconsin.
Okay.
We've even had them from outside the country,
Texas, yeah.
out on active duty orders where, they're coming from Germany or really wherever a station is located.
I think our country can really appreciate, and I say this sincerely, about keeping boots out of the
Yeah.
country now. The ones that are experiencing the PTSD and the traumatic brain injury, the family members, can really appreciate this, and hopefully this will continue as long as possible. I know there's going to come a time we're going to have to put boots on the ground.
True.
But I think that's the reason the president is moving so, I bet this is in his mind, moving so slowly about doing this, because of the after effects it's going to have. Okay. I had to mention that because this is a serious, serious thing. What about research now? Research is very important on PTSD and traumatic brain injury. Why is this so important to the society?
Let's start with Dr. Saccone and Dr. Swaminathan, who've explained that we're only beginning to address and really understand PTSD. Why is research so important?
Excellent question. Without research, we're not able to make improvements. We're not able to actually even have a baseline of information as to whether something is working or something is not working, or whether something exists or something doesn't exist. So it's even some of those it sounds like almost simplistic questions that are not so simplistic to answer. And so we need to complete the research to be able to gather some data and be able to really then make some changes to implement the appropriate treatment strategies to be able to efficiently diagnose certain disorders, particularly here, our PTSD and TBI. And that's something we're really taking a look at right now is there any way we can really figure out how to objectively measure the difference between post-traumatic stress disorder and traumatic brain injury? As we all know, they're comorbid issues, the numbers are huge, staggering, as we had talked about. I believe you had indicated that
40%.
Yeah, that's those with 40% of those with PTSD also have the comorbid traumatic brain injury. Right. So with that, we kind of want to be able to try to tease those apart so that we can make sure that we're efficiently treating and efficiently diagnosing, because that, of course, will lead to progress for the future and lead these individuals to have as successful of a future as what they want. And that's of course, the goal. Anything to...
So in medicine, we always try to practice evidence-based medicine, meaning like have the treatments have worked? Did it make a difference in patient's life? Are you able to objectively measure their progress? So I think clinical research ties straight into patient care, how we care for the patients. So for example, 50 years back, if elderly men fell and break their hip, they would be bedridden. But now they go into the OR, take out the hip and put a new metal, and they are able to walk the next day. So technology has advanced so much. So the same thing we want to include in our research to see if there is any biomarker or anything specific that can help us diagnose better. Yes, this will make them better, or no, they need more care. So I think it does play definitely an integral role in patient care.
I'd like to add that through all wars, we've had underdiagnosis.
Okay.
We've had men and women who came back from World War I and II and Korea and certainly from Vietnam who had PTSD and traumatic brain injury, but it was unidentified. And so they suffered for years without people helping them. And our goal at this time is to never again have veterans suffer as they have in the past without being responded to. And research, knowing how to diagnose better, knowing how to tell when somebody comes in with these other presenting problems to their doctors or through their family or through their minister or the community, so that they can be seen, identified, and that they can be brought in, and we can reduce the suffering and increase the recognition and treat our men and women who serve with honor.
Well, John, we're going to continue with you then. You're going to tell us what is research is done at the Captain James A. Lovell Fellow Healthcare Center about good researchers.
Well, we have 6 projects we're going to mention.
Okay.
So Dr. Saccone is going to start talking about the eye tracking, and then we'll get to the marriage and the couple that I'll talk about, and expressive arts, and the traumatic brain injury that Dr. Swaminathan will speak to.
Okay. And actually, that is where, at the Rotary, that's what we had discussed, yes? As I had presented on eye tracking. And where that, the whole I guess, interesting piece about that is that we're looking for the biomarker that Dr. Swaminathan had talked about. We're looking for a physical difference that we would be able to target and say, that's definitely not a TBI, or that is a that's TBI, or that's PTSD or not PTSD. So something that we took a look at was eye tracking, which is it's a method of tracking cognitive processes. As we have heard the old adage of the eyes are the windows to the soul. Eyes are also the windows to your brain functions. So the way that a person is viewing the world and viewing being able to, I guess, scan the environment, the way they do that is usually very unique, dependent upon whether or not they have a normal brain or a normal scan path is what we call it. And who knows what normal is, but for whatever we know is normal, in comparison to maybe some other disorders that have been very well researched in terms of this eye tracking methodology. So what they have found is that there are many different disorders that are exemplified through this eye tracking by, again, they scan the world in a very different way. So there's research on anxiety disorders, schizophrenia, a lot of different mood disorders and some thought disorders. But specific to us, nobody was taking a look at what we're dealing with on a daily basis. So whereas that well-researched area has been really great for certain disorders, we were wondering if maybe that would work for us and be as beneficial to us as what it has been for some of these other disorders. And when I say us, that's of course the veterans and the active duty personnel that we're working for and working with. So the goal here, as I said, is to be able to kind of see if they're viewing the world differently through their cognitive processes. And I think thus far, some of our results, when we took a look at a PTSD sample, as well as a traumatic brain injury sample, and then a control sample for some of those normal. juxtapose the normal brains, right? Again, whatever those are. And for us, what the normal population was were service members, veterans and active duty personnel who returned from combat, a combat zone, and they currently are not diagnosed with either PTSD or traumatic brain injury or really anything. We made sure that they pretty much had a clean bill of health medically and psychologically. And so nonetheless, when we took a look at these two different groups, we definitely found some really promising data. Data that I want to, of course, be able to bring to the table, but after we formally go over that, as we're currently in the midst of still analyzing, as well as starting to write up some information to be able to publish out to the community and to our community as well as
Preliminarily, it looks as though this could be very helpful.
Extremely helpful, because what we're already finding, and I can say this in a very general fashion, is that those with post-traumatic stress disorder, chronic post-traumatic stress disorder, definitely view the world much differently than a control group or those diagnosed with traumatic brain injury, and vice versa. There were definitely some very significant differences between the groups all around that really made it's very interesting, and something again that we hope to continue as we started with a very small pilot population is what we call it, so a very small group to see if we would notice any significant differences. And because we did, we of course want to open that up to include even more persons in the study to really see if we can come up with some of that same data, so that again ultimately we want to be able to differentiate more objectively and be able to say that this is PTSD, so let's really target those symptoms. And
now the federal government has shown their interest because there's grants available too, right?
Yes.
If I may comment, we want to recognize our colleagues at the Brain and Behavior Research Institute who assisted us with this research.
Yeah.
We've had the good fortune to receive some grant money, and that's funding Dr. Sacconi's research assistant position, as well as some equipment we're purchasing.
Right.
And we hope to continue our collaboration with both Northwestern and the Brain and Behavior Research Institute
Right.
with these studies.
Absolutely.
Fantastic. Okay, I'm sure our listening audience is happy to know that there are grants and studies in development and trying to get, even though that we feel that there's no cure now, but there must be a long range. They say diphtheria, there was not a cure, but they
Right.
kept working on it, right? And so
True.
now we don't have it. Now we got the Ebola, and I'm sure that will that will happen soon. So
Let us quickly mention the other studies
Okay.
so we can at least identify them.
yeah, we want to make sure we cover all of them. We got
That was
10
that was our big one where we've already started to
Right,
collect
yeah.
the data. But we do have a few proposals that are going through.
Right.
That
So
would be
we are
interesting
trying to
know.
get the traumatic brain injury registry started in collaboration with Northwestern University. So hopefully with that, our goal is to have more multiple prospective studies. So,
And we have another grant-funded study which is on mindfulness, which really has to do with meditation and relaxing. As you can imagine, people who have PTSD don't relax. Hypervigilance means they don't relax. We believe, and there's every indication that mindfulness training, and now all the major hospitals have not only mindfulness, but they have music therapy.
Okay.
Helping people relax will be, we're certain was going to be a useful study. And that's Dr. Lutz, myself, Dr. Sacconi, and Miss Adams, who's a registered iRest therapist that are sponsoring that study. We have two projects with marriage and family. As you may recall from your military time, and the military is kind of founded on the idea of the soldier of one, as the Army says, and that model has kind of been in the healthcare also, where we've dealt with the individual in many of the VAs. Now there's a mandate, and it's a common sense mandate, that we, like private hospitals, treat the families and the partners. If you're in trouble and you need to go to the hospital, your family was there for you. And if I'm in trouble and I'm in the hospital, I want my family there for me. So we believe the same holds true for veterans, that we need to bring in partners, we need to be able to work with the kids and the families. So one of our papers is explaining and talking about how we're going to expand marriage and family services, and that's actually being done with our colleagues from Portsmouth, from Walter Reed, and from some of the other naval hospitals, as well as our Great Lakes Naval Hospital. We have another study where we're working with the Illinois Institute of Technology student, actually Miss Natalie Gala, has written a very excellent dissertation proposal, and that's going before our IRB, and it has to do with looking at the patterns of communication in families and in couple relationships of those who have PTSD between their spouses or partners. And that has not been done. Many family studies in the private world, the Family Institute at Northwestern, but in the VA hospitals, we're only beginning to start to support these very important research with family. And then the other study that I wanted to mention was with the expressive therapies, expressive arts, which you know from the vets who came here.
Yeah.
Again, throughout history, what do people do after tragedy? They sing, they chant, they play drums, they go to their church, they go to their synagogue, they go to their mosque. They find some kind of ceremony, ritual, and they use music and the arts oftentimes to help them. What we're doing is doing that more formally. And actually across the VAs we do have some good creative arts programs, but we're using this specifically with PTSD as a treatment. We have veterans and their partners come in, and we have remarkable movement, people using art and poetry. We have many books authored. We have speakers coming on your show and to the Rotary. So that's called the expressive therapies and the expressive arts and the treatment of PTSD.
Now, do you have the community providing support by coming in too?
Indeed, we've had
They have
volunteers.
to be a joint effort.
We've had Rotary guests. We've had guest musicians. We've had people come in with bluegrass bands and with piano players, and people come in and read. We have actually Marianne Lakovich from Kenosha and her friend Stacy come in, and they play remarkable keyboard, just remarkable keyboard, and bring in poetry and ukulele. So we have community resources who come in. And my friend Greg Rodriguez, who you may recall has been at Rotary and played his violin and his mandolin. So you bet.
This is fantastic. Well, we have to, before we end the program, talk about your message to Lake County veterans and their families.
I may add one more thing.
Perfect timing for that, actually.
As of September, the Department of Veterans Affairs had introduced this app. You know, now everybody has their phone. So this is called Concussion Coach. So it's a free download, and anybody can download it if they have the iPhone. The Android version is coming soon, they said. So they could learn about it, they could assess their symptoms, it's kind of walk them through how to manage it and whom to contact. So all they need is go to vaapps.com, and then it'll be their concussion coach.
Okay, again, that's VA and that's
Apps.
APPS.
APPS.com.
APPS.com.
Correct.
That's not gov.
Okay.
Not gov, yeah.
The short message, Dr. Brooks, is that we want to invite Lake County viewers to remember James A. Lovell Federal Health, the expert programs we have in PTSD and traumatic brain injury, and we want them to know our suicide hotline, which is a national hotline, 1-800-273-8255, and we want them to know our number at the hospital, which is 847-688-1900. And we invite you to call us for consultation, call us for interest, call us to come visit. We want you to know we're a very open institution. We're very proud of the work we're doing, and we invite Lake County to utilize our services.
Again, if they want to call to view your services, they will call what number?
847
Okay.
688 1900, and they can ask for PTSD, they can ask for traumatic brain injury, or they can ask for any of us.
Well, I'm very happy that, gee whiz, that you've taken time from your very valuable schedule to come in and to talk with Lake County, Kenosha County, and Cook County about the James A. Lovell Federal Health Care Center. They heard so much about it, and they probably have not gotten the dialogue, you know, that the three of you have provided about what is offered at the, you know, Federal Captain James A. Lovell Federal Health Care Center. And I have to congratulate Senator Kirk again for his efforts. It took him quite a bit of time. He didn't get it overnight. He had to convince a lot of congressmen to support this this effort. Dr. Let me try this again here now, but Dr. John Patrick Baer, clinical psychologist at the James A. Lovell Federal Health Care Center. I guess I'm a dream about this. As many times I repeated, people, the more they say that you learn, the more you repeat. In marketing, right? This is true. The more you repeat, and you're more apt to follow through with it. You know. So, Dr. Baer, thank you very much, and
Dorothy Swaminathan.
Dorothy Swaminathan.
Correct.
The doctor serves as staff
Physiatrist.
Physiatrist. Oh,
Correct.
boy,
You got it right.
Physiatrist. Physical medicine rehabilitation. I mentioned that I was in physical medicine and rehabilitation service back in '57.
Right.
I was an educational therapist.
Wow.
We had
Okay.
educational therapy, we had occupational
Sure.
and corrective, and
Okay.
but they have I guess educational therapy now is just a luxury now.
Right.
Well, I taught all the commercial subjects and preparing them, but the corrective therapy and physical therapy,
Right.
occupational therapy, is still there.
Yes, exactly.
Oh, okay, and then Dr. Danielle Ciccone, I got that right this time.
Yes.
Thank all three of you for taking time again, and ladies and gentlemen, we hope you have benefited from the information that's been promulgated by the three doctors from the James A. Lovell Federal Health Care Center and the PTS and also Traumatic Brain Injury Service. This has been Community Forum. My name is Dr. Waddell Brooks Sr., your host.